want to get the pointer to come out. Good afternoon to Dr. Kumar, and thank you for your invitation. Can you hear me clearly?
Yes, yeah, we can hear you.
Okay, I will keep talking. Okay, this afternoon I'm going to talk about the aim of regenerative medicine, and then we want, in fact, the topic today is where to treat and how to treat. And I like to change a little bit and to talk about the aim of our regenerative medicine. We need the treatment to be effective and less painful, um, and regenerative injection therapy. I even you have been going through seeing a lot of other topics which is talking about the cosmetics and other treatments in other internal medical diseases. I'm afraid this lecture will only be in musculoskeletal pain, chronic pain, sports injuries, and without talking anything about cosmetics and other internal medical problems. So I have no financial conflict to disclose. And as introduced by Dr. Kumar, I'm the current president of the Hong Kong Institute of Musculoskeletal Medicine, and also the founding president of the MSK US Asia Pacific. And in fact, I teach around the world for musculoskeletal ultrasound and ultrasound guided interventions. I would like to dedicate this lecture to our God and to my Father in the heaven and to my wife for their continuous support and keep reminding me to be a righteous person, and to all my teachers, including those silent teachers, and to all my patients. And the regenerative medicine, in fact, pain management is in fact a cross-discipline practice, and it is also booming in the field of interventional pain management, sports medicine, and musculoskeletal medicine. And tonight, I'm going to focus on how we can make the regenerative injection therapy more effective and less painful. Of course, this treatment is to stimulate the body to regenerate and to rebuild ourselves. And the solution, whatever solution, you have listened to a lot of different talks within this summit, which is very good. That can be hypertonic glucose or isotonic glucose, 5% dextrose, and you can be platelet-rich plasma, can be bone marrow aspirate concentrate, and it can be adipose tissue, and then it can be alpha-2 macroglobulin, and it can be placental matrix or exosomes. I'm not going to discuss about what solutions you're going to use. I like to discuss how we can make a right diagnosis, because still diagnosis is the most important thing. If you couldn't make a right diagnosis, you treat that patient, no matter what solutions you're going to use, you are only treating the patient by luck. If you make a right diagnosis, usually the treatment is not that difficult. And you find the root causes of pain is so important. If you're not treating the root cause of pain, you just suppress the pain will come back for sure. Because if you're not thinking about tensegrity, not thinking why the patient presenting with anterior knee pain is related to all the ligamentous structures posterior to the knee joint, why the patient presenting with patellofemoral syndrome. Okay, so those are biotensegrity and biomechanics. Pay attention to that in the mind. I'm going to illustrate a little bit with the examples I'm going to use in the later part of my talk. And I also find the peripheral nerves involved in the injury, in sports injuries, in degeneration, and in your chronic pain patients. The reason is very simple. It is because of these nerves being sensitized, being involved, then the patient present to have pain. If the patient does not have those nerves, of course they won't have any pain. And then for you to diagnose or to come to see you. Of course, number one important thing after making the diagnosis is you have to deliver, no matter solution you're going to use, no matter injectate, no matter regenerative injectates you're going to use, accurately to the right target. So I urge you to use guidance to do the injection. If you are a good fluoroscopic guided doctors, by all means, do that. And but if you're not, if you're very good, you're young, you're still open mind to learn, I urge you to learn musculoskeletal ultrasound, because you can see the right target. You can see the target. You can deliver the target to the injectate to the targets, and this time you can treat the patient well. Next time when the patient come back to see you again and then say, doctor, you have treated me last time very well. Can you redo that? Can you repeat the treatment? And then reproducibility is number one importance in your regenerative medicine practice. And also, if you're using musculoskeletal ultrasound to guide the injection, you can avoid puncturing the nerves, arteries. Of course, that puncturing those nerves and arteries will cause pain and cause more pain, and even cause hematoma, cause neuroma, nerve damage, even more pain and even more problems. And then also using musculoskeletal ultrasound is safer to the doctors and patients. Important. And also, if you can do a musculoskeletal ultrasound guided nerve hydrodissection or blocks before you do your RIT, it will be much less painful to the patient. But at the same time, for people knowing hydrodissection, if you do not know, you can refer to my review paper. In Chinese, we have a saying that if a channel is passing through, that means a nerve or blood vessel is passing through without any obstruction, that there will be no pain. If you have pain, that means something is obstructed, something is stuck. So if you do a hydrodissection, not only you are treating the the macro environment to have more blood supply to the region you're going to regenerate, you also microscopically, you're also treating the micro environment to have to reduce the toxins and metabolites involved in a painful region. So that's so super important. Also, this ultrasound, you for making diagnosis, this is a point of care. Point of care. You can make the diagnosis right on field. If being a sports medicine, I always carry my laptop type of musculoskeletal ultrasound to on green and then to the field and then to support my sportsmen. You can make the diagnosis right away, and you can also do dynamic scanning. There are not many other investigation modality you can think of using this with this benefit. Dynamic scanning is the number one advantage of musculoskeletal ultrasound, both peripherally and also spinal axial. I'm going to explain that with my example. And also, you can see the Doppler. You can turn on the power Doppler. I urge you to use power Doppler instead of color Doppler, because that is much more sensitive to see inflammatory reaction, and also to see the small vessel, the new vascularization that is involved most of the time in neurogenic inflammation or in the structures you're really going to treat. And also you can use power Doppler to plan your injection, see what arteries, major vessels are in the surroundings next to that. Major example is that if you're doing a stellar ganglion block or stellar ganglion hydrodissection, you have to make sure where is the vertebral artery next to the, very close to that stellar ganglion. And also you find the peripheral nerves involved in an injury, in the sports injuries, in a, whatever degeneration you're going to see, and a chronic pain patient, there must be nerves involved. Take acute ankle sprain as an example. The medial dorsal cutaneous nerve and the intermediate dorsal cutaneous must be involved in the ankle sprain. And then so that's the reason why even the ligament has been regenerated, you still complain, the patient still complain pain around that region. And then for this lady with degeneration of the knee joint, remember those supramedial genicular nerves, and that's involved, or the inframedial genicular nerves involved in a severely OA osteoarthrosis of knee joint, which is super important. And also think about the nerves, the peripheral and the central. And I'm going to explain a little bit later. Also, do the musculoskeletal ultrasound guided hydrodissection as said. That's much less painful injection. It's more effective, and you can use much less needle entry point to to complete the regenerative procedures. Okay, I will illustrate with a medial knee pain, which is very common, and a neck pain with referral pain, and to illustrate the whole lecture. Okay, oh, this is a wrong one. Okay, for common knee pain, for example, the medial knee pain, especially during walking and downstairs, super important. Like this lady, this group of patients, they having stage 4 osteoarthrosis of knee. Of course, I think evidence-based, this group of patients should have knee replacement. But what about if they have other comorbidities that they couldn't go for the surgery? Then it's regenerative injection is probably another way to go. You have to treat the patient. So this is how you observe this group of patients walking. The number one observation to me, apart from having this a bit of a degeneration in the knee joint, I'm seeing that the patient is swinging the body left and right, especially to the right side. That's because the right glute max is not firing. And I'm going to feel that knee joint. This is number one important physical examination for the knee joint. I have to feel the knee joint, feel the capitation, feel what structures are really having friction, and feeling that whether that the femur is stable when it's moving against the tibia. So trying to feel the joint line and then trying to feel the painful spot of the patient. Of course, you can have a treadmill and having the patient walking on the treadmill and then trying to feel that. And then that's the most sensitive examination to tell you whether the patient is having ligamentum laxities, the ligament is really lax, or the meniscus is protruded out, or there's excessive friction between the femur and the patella. If this patient is only complaining medial knee pain, and then I have felt felt the knee joint is really protruding with the meniscus protruding out, and then compressing really on the medial genicular nerves, and then I'm going to feel with my probe now, and then you're going to see that the left side is the femoral condyle, the right is the tibia, and the meniscus is protruded out each time when the patient is standing straight. And that will compress either by the osteophytes or by the protruded meniscus, really squeezing on the medial collateral ligament and also the supramedial and inframedial genicular nerves, which are combination of the saphenous nerve, obturator nerve, and the nerve to vastus medialis. So this is a medial. What about the medial knee pain? Is walking is only with a complaint. The patient only complain the medial knee pain on walking downstairs. You can have the patient keep walking downstairs, but at the same time, you scan the medial joint line. Of course, I felt the patient before I put the probe on, and then you're going to see that during that downstairs movement, especially when the knee is semi-squat, and then you have the spur of that femur is really impinging over the medial collateral ligament. Oops, this is I'm not going to talk about that. Okay, what about the medial knee pain is on walking and then you're trying to scan? You can have the patient walking on the treadmill, and at the same time, you're going to see that each time during that the straight face, stance face of that gait cycle, the meniscus is protruded out and squeezing over you can see a bit of the nerve structures, the fascicles of the nerve right outside the medial meniscus. And for that lady, severely OA knee, you can see that when she's walking, that is basically bone on bone. And it's there is not much meniscus left between the two bones, but you can see that structures keep pushing over the medial collateral ligament. So that's the structures you're going to treat. What about how you can confirm the lesion? If the patient is not needle phobic, most of the time I would just pass a dry needle under my ultrasound guidance and then to below the lesion and above the lesion. Take a nerve as an example. You can see that this nerve, common peroneal nerve, is having a very swollen fascicle inside the nerve. Then I'm going to pass the needle below it and above it. And I'm going to flick that needle both above and both below, and it's to see whether I'm reproducing patients' neuropathic pain. Of course, you can use electricity, just like those Chinese medicine doctors. They put the dry needle in, and then they use electricity to treat patients' neuropathic pain. This is, in fact, a very sensitive way, and then you can also relieve patients' pain for a few hours to a few days. What about, I still want to really confirm the suspected lesion is the root cause of the patient's pain, and I want to do a diagnostic block. Okay, so this is, for example, a patient with medial genicular nerves, and then you see these nerve fascicles swollen, and you want to pass a needle, and then with a solution, and then trying to really to inject under ultrasound guidance, and then to that structure, and then you want to block with as minimal solution as possible, and then you're trying to just block this one here. And if this blocking can totally relieve patient's pain, that means that is the root cause of the pain. And then you have to do injection and then put your whatever PRP, hypertonic glucose, to that area. By the way, I'm not a fan of steroids, so I will not put steroid into that space to cause further damage or further degeneration. What about if the patient is with this osteoarthritis, and you see MRI, you can see that apart from the osteophytes, apart from the very thin meniscus, almost the lateral meniscus almost gone, and you can see that there's some intraosseous bone bruise, subchondral bone bruise, bone edema. So where to treat and how are you going to treat? Of course, you see the whole structures, even that there are thinning of the cartilage, osteophytes. You can see the ligaments are not doing well, and there may be some tendinosis, there may be some other problems. So once again, if you really want to comprehensively treat the patient with RIT, don't waste your precious injectate. I urge you to see those good paper talking about prolotherapy. And this is a paper published in the Annals of Family Medicine, which is a very high impact journal. And then you can use this QR code and then scan that and then to get that paper. And also, if you really want to do an intra-articular injection, in fact, if this is a real-time lecture I'm giving, I will ask the audience whether this is a good injection or not. Remember, let's redo this from here. I want you to pay attention to here. During the injection, can you see some separation between the fat pad and the quadriceps tendon? If you're seeing this during your ultrasound guided injection, this is not a good injection. This is a failed injection. You can see that immediately after the injection, the fluid, in fact, has been trapped inside the fat pad. Even you flex the knee joint, the fluid is still there. This is the fluid It's not inside this suprapatellar fossa here. It's inside the fat pad underneath the suprapatellar fossa. So this is a failed injection. So if this is a very precious bone marrow aspirate, you're wasting your product. You have to aspirate this out and then redo that and then put that into the suprapatellar fossa, which is intra-articular. So now you can see that when I'm flex the knee joint and then all the fluid, you're not seeing that fluid. So these are the, I just let you see one more time here. When I flex that, oops, it should be here. You can see that even if I flex that, there's no engorgement of the fluid. That means this is the fluid is really inside. Once again, I urge you to do whatever injection you're going to do for the patient to do ultrasound guided hydrodissection of nerve first. So this is a review paper published last year in the Journal of Pain Research, which is and talking about the rationale, methods, current literature, and also the theoretical mechanism about this technique. And use this QR code and get the paper. And this is another paper published in the Regional Anesthesia and Pain Medicine by Professor Philip Penn and their team. And they have done extensive fresh cadaver dissections, and then each line of these color lines corresponds to one nerve, which is one of the contribution to the supramedial genicular nerve and the supralateral genicular nerve here. And so you can see that this is how they postulate if you want to put your radiofrequency ablation needle in this region, and then that's how they do the radiofrequency ablation. So this is corresponding very well to the teaching we are doing, that this is the supramedial genicular nerves. And then this chapter is also published in this textbook of the ISSPS 2016. You can use this QR code to get the last chapter of that. And then you are going to see all the techniques I was teaching for the genicular nerves, block and hydrodissection. And so for the supramedial genicular nerves, we are hydrodissecting at the level of the above the just proximal to the adductor tubercle, and then with a needle, at least you're going to go through 3 layers. The most superficial one is mainly by saphenous nerve and maybe nerve to vastus medialis, and the intermediate one is by the saphenous nerve and also the vastus medialis. The one very close to the bone here, to the periosteum, is by the operator nerve. And you're going to the backside of the knee joint. You're doing this hydrodissection of that common peroneal nerve, lateral sural-cutaneous nerve, and the tibial nerve. And remember that the posterior genicular plexus obtain most of the branches from the tibial nerve. And the innervation, a lot of time branch out inside the sciatic nerve sheath. It's very proximal. So, but at least you block here, and then you can do a knee procedure very well, and the patient will not feel it. So for this patient having a bone bruise, are you only treating the intra-articular and also periarticular and then all the ligaments and tendons? I would like to introduce this new technique to you. This is ultrasound assisted. At least we use ultrasound to guide the needle all the way to the periosteum. I mean to the bone crack. You can see the a crack in the in the bony cortex, and this crack does not have blood flow, so it's not a nutrient foramen. And then after the needle getting into that hole, if you use a little bit of force, and then the needle will go into the intraosseous. And this is only a 25 gauge needle. And remember, when I was doing that injection, you want to observe the typical artifact. You can see this power Doppler artifact of the intraosseous injection or intraosseous aspiration. So when you're taking the bone marrow, you're going to see this type of artifact right here along the needle. It's a vibration along the needle right here as well. If your needle is really going into the intraosseous region, and when you inject or aspirate, you can see that from the B mode here, there's no expansion at all. So that means you are not injecting anything outside the bone, but you can see this vibration artifact along the needle. So that means your needle is really inside the bone. Of course, I have the privilege, I can use fluoro to inject dye and then to see the flow of the dye around into the target, and which is corresponding very well to the lesion. And after the injection of the intraosseous platelet-rich plasma, and this bony defect regenerated. So this is the paper published just the last month. So you can use this QR code and get the paper. So my next example, I'll finish with this example, is the patient having neck pain following refurbing pattern. Once again, I want you to think outside your usual way of thinking. Try to transform your clinical test to dynamic ultrasound scanning. In fact, this is a whole lecture or a whole workshop using how to do dynamic ultrasound scanning. This is, you know how to do a Sperling test. And I'm trying to do a Sperling test with the patient supine and trying to rotate and axial loading of that and an extension of that neck, and then trying to really to see whether there is any impingement onto that C6 nerve root. You can see a little bit of and then also asking the patient whether they complain any tingling or numbness down the upper limb. And also, if you really suspect the disc is really having trouble, you can do a dynamic scanning of that disc. Take C5-6 disc in this patient as an example. This is 6-7, this is 7T1, and that's a 4-5 disc. And you can see that there's narrowing between the C5 and C6 space. And then also it's a little bit of protrusion and a little bit of a spur over that C5-6 disc. And when the patient is rotating the head and neck, not much rotation along between these two bones. The other bones are rotating, but this one does not rotate that much. So what about flexion? I flex the patient's neck, and this time you can see that during the flexion phase, the space becomes even more narrower in the front, right here. And they're trying to extend, and the space increase tiny bit in the front. Of course, I repeat this again and again, and then trying to really seeing that you can use your digit, you can use your hand to palpate, really palpate this area to see whether that's tender and reproducing patient's pain. And remember, you have the longest colline muscle above it, and then also you are palpating. If you're palpating here, you're also palpating some of the sympathetic trunk. This is when you put the transducer through that disc. This is your spinal cord, and that's the lateral, the right lateral mass, and this is the left lateral side. This is a disc. You see some debris inside the C5-6 disc, and then when you're rotating the head and neck, and you are seeing that there is some debris which is really moving, which is not good, which means the disc, in fact, is having desiccation, is torn, and there is some debris really moving like that here. So that's abnormal. This immediately telling me that I don't have to take a MRI. I know this disc is desiccated. Okay, so this is how you can use a dynamic ultrasound and then to make the diagnosis of that. So for this patient presenting with interscapular pain, apart from the refer pain pattern, remember, this can be a refer pain pattern from C5-6 disc um, by provocative discography. You can also have this region like dorsal scapular nerve entrapment and then causing the refer pain. You can using your ultrasound to guide the needle, your dry needle, and then to below that levator scapulae. This is a SCM, but this is upper trapezius, and that's your levator scapulae. This is your first rib, and you can scan your underneath that, and then use the dry needle trying to whether you can provoke that along that pathway of that dorsal scapular nerve. If the pain is not reproduced in this location, I'm going to go to the middle scalene. Then I use my dry needle and then trying to stimulate when this dorsal scapular nerve just comes out from the C5 nerve root. See whether I'm reproducing patients' interscapular pain. So this is when the dorsal scapular nerve very well shown inside the middle scalene, right here. This is the nerve. And then remember the posterior scalene is just below it. And the vertebral artery is right here. Okay, so if you suspect the patient is not having the disc problem, if the patient is not having that problem, remember the cervical facet can also have referral pain pattern down to the same interscapular region. So you can do your, if that is a cervical facet problem, of course you can block the cervical facet, or you can block the cervical medial branch. Take this medial branch as an example. I would like to scan that structures before. Usually when you're scanning the cervical facet, the facet can be open and closed when you do the flexion and extension, and which I didn't have example here. If I still have time, I'm going to show you the lumbar spine facet. But I think the time is very limited
You
here.
have time, you can go.
I have time?
Yeah,
Oh, that's good. That's good. So then for this one here, you can see that I'm trying to do my medial branch first. After the medial branch, then I will turn the probe 90 degree and redirect the needle a little bit. And then this time I'm going to go to that facet. And then the facet is having a double contour, and it is between the two bone here. Let me show you, stop here. Okay, if I stop here, this is the medial branch location, except the C23 here. C23, the third medial branch
Riesci a
is
fare un po'
right
di video
overhead. Sorry? Okay, so I go back to the joint here. You can see that this is the C23 facet, and this is the medial branch of the C3. And remember, that's the medial branch is really covering the facet. So before I go to the facet joint and then put my PRP in, I will hydrodissect this C3, that is the third occipital nerve, medial branch first. Then I go to the facet joint and put my rest of the PRP into the facet. This is a C3-4 facet. But the C3-4 facet, remember, the C4 nerve medial branch will be here. The C3 medial branch, apart from being the third occipital nerve, will also give a tiny bit of branch to supply this facet. But this facet, within this trolley here, you only have the C3, the branches of the C3 nerve. You're not going to get your third occipital nerve or the third medial branch very well. You have to go to here to get the third occipital nerve. But if you want to block the C3-4 facet for the medial branch, you have to block the C3 branches here and to block the C4 branches, which is basically this one here. So you remember the medial branch is a little bit different between the C2-3 and the C3-4. Of course, in this picture here, I'm not going to talk too much about the suboccipital, but you can see the dura. Oops. Oh, let me get back to that part. Okay, let me stop a little bit here. So this is the inferior in obliquus capitis inferior muscle, and you already have your greater occipital nerve wrapped around this, and then going to coming up, and then right here you have your myodural bridge of that obliquus capitis inferior, and this is the dura, and that's a spinal cord. So this is the intrathecal space, and so that's and on top of it you have your semispinalis capitis and also your splenius capitis, and you also have your upper trapezius on top of it. So that's for the cervical medial branch and also cervical facet joint. If this is patient with, apart from having referral pain pattern to interscapular pain, and then the pain is really already involving the cervical nerve root, remember you can also hydrodissect that cervical nerve root, and remember the culprit and the money shot is right below the nerve root right here. So you can hydrodissect that nerve root and then to get rid of the pain, and then you can get a very good relief. And also the pain, the medication, if, of course you're going to have a bit of a numbing solution. The numbing solution is going to flow from the neural foramen and all the way into that epidural space, and then also you can go into to block that epidural space very well within this approach as well. And then again, you can get this video um, online by doing this using this QR code. Back to our patient with a referral pain pattern like that, and then the patient is still complaining pain when you do the facet joint, when you do that dorsal scapular nerve, and when you even do the nerve root, still pain. Okay, so remember, this is a C5-6 disc provocative pattern. Let's talk about the innervation of the disc. Remember the disc, posteriorly, it is innervated by the sinovertebral nerve and also the direct branches from the primary ventral rami. These are the nerves supplying the posterior part of especially the annular fibrosis, and a little bit to the nuclear pulposus. So the nuclear pulposus, it receives innervation mostly from the sinovertebral nerve, which is the branch out from the ventral rami. And the front part of the disc, especially the annular fibrosis, that's mainly getting the nerve supply from the great rami communicantis, and it's basically the nerve from the sympathetic trunk. Remember, this is sympathetic trunk supplying the anterior part. That's the reason why you have to know how, if you want to treat a cervical disc, you have to know how to treat the cervical sympathetic trunk and also the sympathetic nerve. And also, my initial hydrodissection is go to the front part of that cervical disc, and then you could hydrodissect that outside the annular fibrosis to get all the sympathetic nerves supplied to annular fibrosis first before I drill my needle into the annular fibrosis. And also there's one important ligament. This is the anterior longitudinal ligament, which is right in front of the disc. And this ligament is also supplied by the sympathetic nerves in the front. And also strengthen this part of the annular anterior longitudinal ligament is also super important to treat the Bowles tensegrity of the whole patient's neck. Most of the time, we know how to treat the ligaments from behind, and then treat the capsular ligamentous complex of the cervical facet, and then treat the ligamentum nuclei. You can treat your lamina with a multifidi attachment. You can treat your transverse process on the backside to treat those levator scapulae origin. But most of the I have not seen any teaching in the world teaching you how to treat the anterior longitudinal ligament. So in probably in my workshop, that's the first school teaching this. So again, this is the approach, how I can approach the anterior part of the disc. This is the C5-6 disc. And you have a longus colli muscle here. You have the sympathetic trunk is right over underneath the prevertebral fascia outside the longus colli. You have your esophagus here, and you have a needle, which is going hydrodissecting that the top part of the annular fibrosis first, then you can go to the disc and then do your injection. I am not a fan of treating the nuclear pulposus. Most of the time, I like to treat the annular fibrosis to strengthen the annular fibrosis to prevent further collapse of the front part. In fact, if you raise up the front of the disc with some height, the posterior protrusion can go backward. So this is just biomechanics. And you can also see the thyroid gland, the carotid artery, and the internal jugular vein right here. And the setting of the patient is patient supine, a little bit of hyperextended neck. And sometimes you have to put a small pillow underneath the both shoulder and or the upper back to make the neck a little bit of an extension, and then to expose that area very well. The machine in front of you. And this is the operation theater setting. And then I have the fluoro machine, and this is a seen an AP view. And then I'm going to see and injecting a bit of the dye when it's my needle is entering just enter the annular fibrosis, and then to see the spreading of that dye. This patient is already having a desiccated disc. That's why even the needle inside the annular fibrosis, you can see the tracking of the dye all the way to the opposite side as well, and then to the whole disc. Okay, so the last one is a case sharing. Is a 40-something-year-old male, fit, active, competitive sports, running, right shoulder pain on an abduction, and it doesn't come back at all. Okay, so again, after the conclusion, I'm going to show you the lumbar facet dynamic ultrasound, which Dr. Kumar.
So how long it will be?
Just 1 minute. Okay, so
Yeah,
make the right diagnosis, remember, and then find the root cause, and find the inflamed and swollen nerves, and make the ultrasound, musculoskeletal ultrasound to guide needle, and to guide the injection, and also do the musculoskeletal ultrasound guided hydrodissection or the block of the involved nerves before you do your whatever RIT. If you really want to learn all those techniques, I hope next year, this year will not be happening, but next year in 2022 in Hong Kong, the Chinese University of Hong Kong should be in the last week of June. We're going to have a fresh cadaver workshop, and it will be 1-to-4 faculty ratio. And so just I want to show you that the facet opening and close is like this. During the flexion is opening, during extension is close. So you can use your ultrasound to guide flexion to see that the two facet, the superior articular process and the inferior articular process during extension will be approaching each other. And during the flexion phase, it will be opening and then separating the inferior articular process and the superior articular process will be separating with each other. Okay, and during you turn the probe 90 degrees, this time you can see that during the flexion and extension, you're going to see the two articular process just separating with each other, but at the same time, during the extension, no debris inside the joint, but during flexion, you're going to see the debris inside the joint right here. That's abnormal. So I think this is, I didn't include one of that for the cervical facet, which is very similar. And I hope you enjoy my lecture. And if you really have any things to ask, you can ask me later on to send me email. And my email should be available when you scan whatever journal of myself, and then you're going to find my email. Thank you so much
Thank
for your
you,
attention.
Stanley. That was an excellent and video presentation, and I think it will help a lot of pain physician and orthopedic surgeon, neurosurgeon